Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. This is the second installment of our Sleep and Mental Health series. And as a reminder, this content is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. By the mid-20th century, sleep medicine did not just become measurable, it became treatable. And once medicine realized it could pharmacologically induce sleep, the floodgates opened. This is the era where psychiatry, for better and worse, learned to equate sedation with treatment. The first major wave began in the early 1900s with barbiturates. Barbiturates were the original sleep medications. Drugs like phenobarbital and secobarbital produced rapid, deep sedation. For the first time, physicians could reliably knock out insomnia. Patients slept. Doctors felt effective. And the medical system moved fast. But barbiturates came with a brutal trade-off. They had a narrow therapeutic window. The dose that induced sleep sat uncomfortably close to the dose that caused respiratory depression, coma, or death. Tolerance developed quickly. Withdrawal was severe and sometimes fatal. Overdose deaths rose quietly but steadily, often mislabeled as accidents or suicides. From a psychiatric standpoint, barbiturates blurred an important line. They did not restore sleep architecture. They suppressed the central nervous system globally. Sleep looked deep, but it wasn't physiologic. REM sleep was reduced, cognitive effects accumulated, dependence became common. By the mid-20th century, the risks were impossible to ignore. Medicine needed something safer. Enter benzodiazepines. In the 1960s, benzos were introduced and rapidly embraced. Diazepam, better known as Valium, became one of the most prescribed drugs in the world. Compared to barbiturates, benzodiazepines felt like a breakthrough. They were safer in overdose, they caused less respiratory depression, they reduced anxiety and muscle tension while promoting sleep. For psychiatry, they seemed almost tailor-made. Treat the anxiety, and sleep will follow. And for a while, it worked. Benzos became the default treatment for insomnia, anxiety, agitation, and distress. They were prescribed liberally and often long-term under the assumption that the risks were manageable. But cracks began to appear. Tolerance developed. Patients needed higher doses to achieve the same effect. Dependence followed quietly, often unnoticed, until discontinuation triggered rebound insomnia, anxiety, tremor, or panic. Sleep became more medication dependent rather than regulated. More importantly, benzodiazepines altered sleep architecture. They increased total sleep time, but suppressed slow wave sleep and REM. Patients slept longer, but not necessarily better. Daytime cognition suffered, emotional regulation weakened, falls, memory impairment, and motor vehicle accidents increased, especially in older adults. By the 1990s, a new solution was proposed. If benzos were too broad, maybe we needed something more selective. That's where the so-called Z drugs entered the market. Medications like zolpidem, esopiclone, and zaleplon were marketed as modern sleep aids, targeted, cleaner, and safer. They acted on similar receptor systems, but promised fewer side effects and less dependence. For a time, psychiatry and primary care embraced them enthusiastically. But the story repeated itself. Z drugs still produced tolerance. Dependence still occurred. Next day grogginess, impaired driving, and parasomnias emerged. That's sleepwalking, sleep eating, and even sleep driving. Once again, sedation was mistaken for restoration. The deeper issue became clear. Inducing unconsciousness is not the same as treating insomnia. By the end of the 20th century, sleep medicine reached an inflection point. Pharmacology alone wasn't fixing the problem. In many cases, it was perpetuating it. Insomnia wasn't just a neurotransmitter deficiency, it was a disorder of conditioned arousal, circadian misalignment, and maladaptive sleep behaviors. Areas medications could mask but not correct. These realizations set the stage for what comes next in sleep medicine, a shift away from sedation as the primary solution toward treatments that restore sleep regulation then override it. In the next episodes, we will dissect modern sleep pharmacology with precision, what these medications actually target in the sleep-wake system, where they make sense, and where they cause long-term harm. And we will begin laying the groundwork for CBTI, the first-line treatment most clinicians were never properly trained to deliver. The future of sleep medicine is not about stronger sedatives. It is about smarter treatment. Thanks for listening. If you found this episode useful, share it with colleagues across disciplines. Until next time.